Hi everyone, this is Tracy Wynn, and today my literature review is going to be on the preliminary results on the impact of simultaneous palatal expansion and mandibular advancement and its effects on the respiratory status recorded during sleep in children suffering from obstructive sleep apnea. So they tested about 103 children in this group, and they looked at children that were diagnosed with obstructive sleep apnea and that had class 2 malocclusion. What is class 2 malocclusion? Class 2 malocclusion is when the mandible is set back in relationship to the maxilla, the upper jaw. And what they did is they made an appliance that expanded and advance the child. And then they followed it through with PSGs and sleep studies. So let's dive into it. First, before we do that, I do want to review the benefits of expansion. So this, again, can be found in Module 3, Evidence-Based Treatment for Expansion. So this module it's about like an hour or two, but it really goes into the literature. But a quick review, we know that we have a lot of literature to support that maxillary expansion does change the nasal structure. It does increase increase the nasal volume and changes the function of the nose in a positive way. We also know we have studies that show that when it does that, when we expand the arch, that the mandible actually gets dropped down and displaced forward. As we improve the airway, what we also see is that the head posture changes and the tongue posture changes. And with all of these anatomical changes, we know that it actually reduces the AHI score, which that is the metric for obstructive sleep apnea, your RDI, which is your respiratory distress index, oxygen desaturations, and overall sleep quality. And at the end of the day, what really matters is how does a child feel? And we do have literature to support that it improves the quality of life. So please review this in your Module 3, Evidence-Based Treatment for Expansion. The second thing I want to review is in Module 3, we have evidence-based treatment for, actually it's correction, it's retrognathic mandible, not protraction on the bottom. But basically we also have protraction, but a review with the retrognathic mandible, which is your class 2s, we know that by treating that, again, we can reposition the mandible to go forward. We're also seeing that as the mandible goes forward, the tongue and the hyoid bone also goes forward. By bringing that lower jaw and the tongue forward, we're opening up the oral pharyngeal space, changing the relationship with the teeth and the bone. And again, we are seeing changes in sleep disordered breathing symptoms, mouth breathing, and snoring. So please review this in your Module 3, evidence-based treatment for the mandibular retrognathia. So now let's look into the study. So this is the appliance they use. I thought it was a really neat appliance. I mean, basically you have an upper expander and then you have a lower fixed appliance. So the lower is not expanding. So we're not doing what we call bimax expansion. And what bimax expansion is when we expand the upper and the lower jaw at the same time. This study only looked at expanding the upper jaw. And once the upper jaw was expanded, they took out the little the center expander and put class. You can see this little hook that hooks up to the lower jaw to advance the lower jaw. And so it was advancing the lower jaw at about 1 to 2 millimeters. And so the child can feel pretty comfortable. Now, again, this technique was used on children that had high narrow palates, that had obstructive sleep apnea, and that also had a lower jaw that was set back. So really cool design. I thought it was pretty neat how they just did the expansion first and then they added the advancement. And again, this was on children. So let's look at this study. As you can see in the model, the lower jaw is kind of set back. The upper jaw is kind of narrow. I mean, it's interesting because you see the child, I mean, has some spaces, but when you look at the two arches, you can definitely see the difference. So what was the expansion protocol? So the first 20 days, they expanded it once a night. So one turn a night for 20 days. And then on the 10th, on the basically after the 21st day, they did 2 turns. So they started off with slow, 1 turn a night, and then they jumped it to 2. And this was for 30 days. And it was just the upper expander, not the lower. They kind of reevaluated, and if they didn't get enough expansion, they would do it again. So, and if they got enough, they would kind of stop. And then you see that once they got the upper arch developed, the next thing was to bring the lower arch. So they didn't really do it exactly simultaneous. They did the upper arch, but they kind of followed it with the lower arch. The complete, and they held it for 9 months. So let's kind of look at the results. So I'm pretty much in agreement with most of the literature that looks at obstructive sleep apnea and expansion. We do see an improvement in the AHI scores. Now, one thing about children is when we say a drop from like a 5 to a 7 or a 5 to a 3 or a 7 to a 2, children, every point counts. Like a 1 apneic, an AHI of 1 is considered, obstructive sleep apnea. So I think it was really nice. I mean, we got more than a 50% reduction overall. So in the statistical world, it's a cure, 50% reduction. So the AHI, again, this is no surgery. This is just craniofacial changes to the face. So the AHI went from 5.3 to 1.4, oxygen desaturation improved. The interesting thing with the study is they looked at the arousal index and periodic limb movement, and they found that actually didn't improve. And I'm going to go into the whys on that. And then when they look at the sleep questionnaire, and this questionnaire is on the Shervin's questionnaire, and this is actually, I didn't put it in there, but this is actually in your module 1, where I talk about the pediatric questionnaire. So we actually use this on our in ASAP pathways. And the interesting thing here is when they while the sleep metrics got better, the overall sleep quality really didn't improve. But again, this is a sleep questionnaire that's reported by the parents. The mouth breathing really didn't improve that much. I mean, well, it did improve, but they still had some yes answers. The interesting thing is the ADHD, or the question that is related towards the ADHD, which is about concentration and agitation, parents still reported that the child still had a hard time concentrating. So the important thing to kind of note from this, and this is something that we teach at ASAP, is it takes an entire team to treat these children. We are not going to fix everything. There's so many different levels, so many different things that we're looking at. And so it's so important for us to really talk to our medical colleagues about this. So in conclusion, when they looked at the study, what did they say? So they said, despite the significant improvements in respiratory during sleep and AHI, they found that the sleep quality wasn't totally restored. And for me, that's okay, because we're not supposed to fix everything. That's where, our medical colleagues have to kind of help us along the way too. I find that in my clinical practice that once a child gets a diagnosis of ADHD and is on medication, it is so hard to reverse that. So hence why at ASAP Pathways, we really stress the need of early intervention before those behavioral problems set in. Another thing that they said that, well, if we really think about it, yes, changing the face does improve ventilation. And there's several studies that look at sleep apnea and anatomy, and there's so many treatments that is directed at the anatomy. And by changing the anatomy, we can restore some symptoms. It doesn't fix everything. So it's not a cure-all. And I think many people think that, oh, if I do this, I'm going to fix it all. And there's so many different layers of obstructive sleep apnea, sleep disorder breathing. So we cannot be expected to fix it all. Again, it takes a medical team to really help you with this process. The interesting thing, that the last conclusion is there is no controlled study. And I love how it said there's an ethical concern of not treating patients during the pubertal growth spurt. And I think this is really important when we talk to some of our colleagues that don't want to treat, like that there aren't good studies. And the reality is, I mean, these are children. I mean, we're not going to have studies for no treatment, because then what are we doing to these children if we don't treat them? So I thought that was a really nice thing that they highlighted this. And you'll see this ethical concern on a lot of studies, because there aren't control studies. If you think about the monkey study, I mean, there's no way we could have done the Harvard monkey study and plugged up babies' noses and see how they're going to develop. So unfortunately, a lot of these studies will not be done on humans, because it's just not right to watch that happen. So but one of the things I do want to touch upon at the periodic limb movement, and I am so thankful that I have Stacy Ochoa and Michelle Weddle. They are really heavy hitters in the sleep world. I started in the sleep world as a restorative dentist, so I'm kind of like diving in on the pathophysiology of sleep. I'm all about like dentistry and anatomical changes, but they always have to reel me in about, hey, Tracy, there are other sleep disorders, and we really need to understand the sleep disorder. So this is a slide courtesy of my good friend and founder of ASAP, Dr. Stacy Ochoa, in Module 1, Medical Comorbidities. She really talks about all the other disorders. And one of the things I asked her the other night, I said, can you talk to me a little bit about periodic limb movement? Isn't this one of those that is not about anatomy, and this is something we really have to understand, because there are many people that are testing children with home sleep tests, and you can't see restless leg syndrome. So restless leg syndrome can probably be not dictated, but can be seen in a PSG, which is an in-lab sleep test. So I thought this was a great slide. Basically, periodic limb movement is episodes of simple repeated muscle movements in the sleep. This is why it's important for us to have a video of the child sleeping. And in-lab sleep tests, they do have videos of children sleeping. It's unable to control them, can severely disrupt the sleep if it causes arousals, and you see sleepwalking and leg pains. And I thought this was a great slide, but basically 80% of people with restless leg syndrome also have periodic limb movement. It could be linked to low iron. Iron is essential for many biological functions, including neurotransmitter synthesis. I mean, this is an amazing slide where we look at iron and vitamin D. So I really invite you, if you haven't had the chance to hear Stacy Ochoa talk about vitamin D and the non-anatomical, I highly recommend you to hear her speak on it. I believe we have another one-day webinar coming up in March. So if you haven't heard her speak, absolutely amazing. But this is also in your Module 1, Medical Comorbidities. So I'm going to end it with those of you that are not ASAP members. We actually introduced a new program that's for education package only. Obviously, we want you to join the comprehensive package. The comprehensive package is actually for you to really get in and implement. We have a private Facebook forum. We do monthly webinars. So there's so much involved with that. But those of you that are not ready to take the plunge and not ready to implement and just really want to understand what we are and just want to learn and watch the modules first, we do have a membership education only package for $5,200, and you get a lifetime access to these modules. So again, like I highlighted throughout the webinar, that there's so many things that we already talk about. And so I hope you join. Thank you for having me.